Hi, so the workup was done with our patient, Mr. Brown. Everything was sent to nSequence. And usually you get back an email relatively pretty quickly, usually that day or the next day that they received the case, and within a few days the webinar will be scheduled. The webinar will be sent out. It's a go-to-meeting webinar, and we send it to everyone. I send it to the restorative doctor, I send it to the implant rep, the lab technician, Krista here, who is our implant coordinator. And the more people we have on the webinar, I find that all the questions are answered that day, all the parts and pieces we're going to need for the cases ready that day, backups are ready that day. Everyone's on board for the case. So the webinar is another check and balance to make sure that we're ready for the case down the road. After the webinar is performed, usually it could be anywhere from 15 minutes to a half hour. The lab technicians at nSequence are excellent. After the webinar has been approved, you get an email of the workup. So all in all, I usually tell the patients from the day they walk in, from the workup, usually we say 3 to 4 weeks, and about a month we tell them for a surgery date. And after the webinar that will be shown today, the next webinar will be a live surgery. If anyone's never seen a live surgery for an nSequence case, it would be a great thing to see. We're going to be showing the go-to meeting now for the planning for Mr. Brown.
Okay, so the initial records, everything looks good. The one discrepancy that I'm seeing is from the photos to the bite that was sent to us, but you used bite blocks to, I think, put him into the position you wanted him in. So that's the bite that you're seeing here on this side.
Charles, this is good. You're good. Yes, you're correct.
Okay, perfect.
Yeah, I did it on purpose. First of all, the patient's bridge is mobile, so when he occludes, his bridge actually moves up and down. Yeah, okay. And he's got a heavy bite, so he can generate a lot of force. So what I'm trying to do is, what I did was I opened him up. That's the reason why there's a discrepancy and the teeth aren't closed on the preoperative, yes, the virtual mounting there. The goal is to try to keep the teeth generally the same size, but bring the teeth posteriorly into contact. And if we can get some anterior contact, yeah, perfect. So you're overlaying the other teeth, great. I don't want to have such a deep bite. And then the other thing is his midline is off, and we want to try and align that with his lower. All right, yeah, so what I'm looking at here, so you move the teeth a little more, you moved them a little more palatal.
Correct, yes.
Oh, good, you aligned the midlines, perfect. So you moved the upper anterior teeth more palatally. You moved them in compared, can you toggle back and forth from his natural, well, his current bridge to this? Okay, so we moved the teeth in. So I understand why you did it. So I'm going to explain. So if people don't understand, we opened the vertical up, and by opening the vertical or making space between the upper and lower teeth, what we're doing is we're making more space, particularly in the anterior. And in order to get those anterior teeth in contact, you had to bring them in with using the tooth library that you used. Instead of bulking the lingual or the palatal of the teeth out, you just move them in.
Correct.
Which I don't think will be that big of an issue. For instance, if we wanted to keep the teeth in the same, facial position, do you have the ability to bulk out the palatal of the teeth to bring them into contact? If you'd like to make them thicker palatally?
Yeah, we can do that.
All right, well, I don't know if we necessarily have to do it here for Jack, but I'm glad that we could do that. If you could basically keep the facial, if we wanted to keep the facial position of the teeth in where they were pre-op, and we could still have them in contact on the lingual or the palatal.
Yeah, we would just, we'd thicken it up here.
You can thicken it up a little bit?
Yeah.
Can I see, can you, yeah, okay. Can you toggle back and forth between, even from the lateral view, can I see from the lateral view back and forth between the natural teeth and the mock-up? where it is. Yeah, can you take away the brown, the overlay? Okay, yeah. Is there any way that you could do it like it's like a ghost image over it, kind of you can see through it? Okay. I mean, if I'm really want to get technical, I mean, maybe we can move the anterior teeth a little more anterior and then thicken them from the palate just to get a little more occlusion there.
Yeah, I can do that.
All right, cool.
Okay, so how more anterior would you like these to be?
I mean, just bring him a little more closer to where his teeth are. You don't have to go all the way. Also, we're kind of rotating his midline and things. So certain areas might be out as far as the pre-op, and some may not anyway. But it's okay. I'm just going through this as from an exercise perspective to see what we can and can't do.
Sure.
Because for this patient, if we moved his teeth slightly lingual or palatal compared to where he is, I don't think it's going to be a major difference. I think that we're okay. I mean, when I look at the teeth, another thing that I see from the shape of the teeth, 8 and 9 look a lot more tapered in your mock-up design, and his teeth are a little squarer or rectangular in shape. So I don't know what mold choice you chose from that Vitapan mold catalog, but if there's more of a square one, the mesial distal width looks relatively close, but I would try and opt for potentially a little more of a square one. I think it's more consistent with his old bridge, and then I think it also maybe suits the patient. But again, this is something that the guy has such a low lip line. I don't know if you're going to be able to truly notice it, but these are just the little things that I'm just trying to to work out.
Yeah, his lip line is.
Yes.
But I can, just in case, I mean, people smile
it's so low
when they get this.
Yeah, so the length is okay. And when you look at it a little bit here, Charles, if you look at his occlusal plane looks a little canted, meaning his left side is a little higher and his right side is a little lower. You know, if we're really going to get technical, we can play with that. I liked how you bulked out on the patient's left, the posterior teeth a little bit to fill out his buccal corridor when he smiles. So if you want to, yeah, you made him a little wider, a little broader. I like that compared to the pre-op, because if you look at his photo, he's also missing some posterior teeth, but he still has it. Just yeah, you just filled it out a little more. I think that's nice. That's nice. I have a question, Charles. What degree teeth posteriorly are you imposing or putting in that setup?
You know what? I'd have to go back and look. Not too sure, honestly. I have to go back and look at the table and see. Because usually what we do is we pick a form, and then we will manipulate, you know, the teeth to, you know, get the best occlusion possible. But I understand what you're saying about what angle of teeth, and I can definitely get that information for you. I just don't have it in front of me right now.
Yeah, the cusp angle. So yeah, so what I'm looking to get like a balanced occlusion, not so deep of a, you know, vertical overlap. You know what I mean?
Sure.
But I know that he has a bridge on the lower, and the lower teeth are kind of flat and they're a little irregular plane. So sometimes, yeah, I mean, putting a cusp tooth there works better than if you did, you know, almost like a 10-degree tooth, you know, definitely not a 0, because then it'll just be too flat and you're going to lose some of the aesthetics. I mean, it's almost like a lingualized setup. So when you have kind of like lingualized denture occlusion, Dave, I don't know if you've heard this, or Leslie, if you have heard this, but lingualized dental occlusion is almost, it's a cusped maxillary tooth, and it's a minimal degree, almost a flat 10-degree mandibular tooth. And so it works kind of like, you get the aesthetics from the cusped maxillary tooth, but then you almost get a shallower guidance off of the lower flatter plane tooth. So that's lingualized denture occlusion. So this is kind of probably what we have here, which is good. You can generate the balance that I'm looking for. You can generate the tripping or the tipping. You can eliminate that because the palatal cusps are steeper than what you can see here potentially. And so when you're sliding in excursions, it's kind of rolling over the lower teeth, and you're not tripping on the buccal cusps.
With Mr. Brown, I was able to get 6 implants in there of varying sizes, but our AP spread overall is really good. It'll allow us to make a nice strong prosthesis that should last a long time, even if he has a strong bite. Also, something we may want to consider is getting him a night guard, perhaps, for the time that he's healing, so he's not putting too much pressure on those implants.
Do you recommend that for most cases?
No, but you had mentioned that he has a strong bite, and so that just kind of set an alarm in my head.
It makes sense. Drew, what's your feeling on night guards?
I think it's fine. I just, I've never done one with them, so just with regard to how well it's going to fit after you do the modification, you know what I mean? Because you pick up those cylinders and the occlusion kind of gets a little different than what it comes as. So we could try it.
I would actually make it for the lower, so we know it would fit, and then make the occlusal portion of it a flat plane, so that his teeth can move around. It doesn't lock him in, and it allows him to move around.
Right. Yeah, I mean that's a nice type of prosthesis. If we can do it, do it.
So yeah, I did 6 implants. I did the one at number 6. I saw this radiolucency here, and I tried to stay away from that. I didn't know if you wanted to go, if you're going to clean it out and go right through it, but I went mesial to it at this time, waiting to see what your thoughts were.
No, that's fine. I'll graft the defect after I take out the tooth, and it should be fine.
Okay, perfect. So the first implant I have, I've marked it as site number 4. The implant size and abutment and everything is over here. It's a Straumann BLX 4x12, and I have a 30-degree abutment on it.
And Charles, can you show the audience?
You'd like that there?
Yes, I like to show how can you show them where the sinus is and how you are just mesial to the lateral side of the sinus, and how we're in cross section, how you're in good solid bone buccal length.
So here's our sinus here. We're right alongside it, but we've got a little bit of a pocket here that we were able to do. And then if we go here, oh, come on now.
Great. That's a great image right there. And just for the audience to see, you can see how the entire implant in the cross section is in good solid bone. We picked a 12-millimeter implant to really engage the most apical part of the most superior part of the maxilla here. You can see how the implant is just lateral to that defect from the canine as well. And usually on these tilted implants, most of the time you have to use either 17, but most often a 30-degree abutment. Don't you find that, Charles, usually a 30 on these?
Yeah, I'd say about 90% of the time you're going to use a 30. There is much rejoicing when, we can use a 17, or even in those, 2 to 3% cases where their sinuses are superior and posterior, that we're actually able to do a straight implant at the most distal ones. But yeah, about 95% of the time, you're going to see yourself with a 30 here.
And also the abutment size, we know the abutment size from this as well. It's a 30-degree, and what height of the abutment is? Can you tell from the setup here?
On this one, for the Straumann, it's for their 30 degrees, it's a 3.5 collar height. And then the cone, which makes up the multi-unit part of the multi-unit abutment, is usually about 2 millimeters.
Yeah.
Here is number 6. This is also a 4x12. This one is a 0-degree abutment.
Charles, can you guys see the occlusal view of that?
Yeah, I was going to ask if Drew's okay with
Yeah. Can we move it a little more
medial
You want more in the single
Um,
canine?
to the facial?
All right. Next up, I don't know
You
why I
can't go
chose an
distal
eight.
to that, correct, Charles?
I mean, I could if you guys were okay with, you know, putting an implant into a recently grafted site from an infection.
Yeah, Drew, there's a defect there.
Dave, I'd rather be safe than sorry. You tell me.
Yeah, I'd rather be safe there.
Okay.
I don't mind.
Leave it.
I don't mind tilting it more facial into you. He has good width of bone there. That if you want to tilt that a little bit more facial.
Well, I'm trying to get the screw hole access out the cingulum of the tooth. I mean, can you angle it like distally a little bit, just so the screw hole is not coming through the embrasure? Yeah.
Yeah.
And then get
Right.
a drop more facial.
I don't want to go at the provisional stage. I
Yeah,
don't
that looks
want
better.
to go
Yeah, I mean,
too buccal because the hole's bigger and I don't want to blow out the cusp. We still have a good path of insertion, so that'll work just fine. Number 8, I have a 4.0 by 10.
Good. I'm happy with that, Drew.
yeah, it looks great.
Number 9, the piriform rim, or I don't know what it is, if it's the piriform rim or something's going on. It could be there, and the computer just didn't pick it up. But I mean, it looks like it's there, so that's why I started off with an 8. But this looks like bone. I'm not too sure what this is.
It just looks like.
I can easily
see. I would put a 10 in there. I
Okay.
think it's just bone. It's just a defect on the CAT scan. It looks like.
Okay.
Thank you.
Okay, so number 9 is also a 4 by 10.
Great.
Okay. Number 11, our bone is getting a little squirrely here, so I did a 375 by 10. Looks like a little bit of bone loss, perhaps some infection. So that's why I started off with a 375. Okay.
Looks good.
Cool. And then number 13, this is a 4 by 12 with a 30-degree abutment.
Great. It looks like, again, same as the other side. You're just skimming the wall, the sinus there, which is great.
Charles, can I ask you a question?
Yes, sir.
How do you determine the cuff height? What are your parameters to recommend the multi-unit abutment with a particular cuff height?
So honestly, it's Straumann that really picks in the 30-degree abutments. You're primarily seeing that's going to be your tallest abutment because of how it's angled. So it's kind of, if you look down here on the pano, it's basically measuring this length here. And with the 30-degree, I like to choose the 3.5 because it's not. It'll sit right at the tissue, but it's not so tall that you're going to end up seeing some kind of metal. Even though it's in the posterior, you want to make sure that all you're seeing is, when you pull the cheeks back, prosthesis and tissue. So if I were to go up to a 4 or 5, you run the potential of seeing some metal there once the tissue resorbs and everything after the bone reduction.
So how about the straight? How about the anterior?
The anterior ones, we don't pick their shortest ones because those have a tendency to go below the tissue level. So we usually pick anywhere from 2 to 2.5, depending on the implant company.
Good. I just want.
Chuck, you made a point of saying the bone reduction. Can you show the audience
to
here
review
after you measure the bone reduction?
Sure. That's there in the orange.
And can you measure from the prosthesis down to, I guess you're looking to get down to the implant level to figure out how much space you have.
Yep. Oh, that's wrong.
So if you could just show a measurement so the audience knows it's greater than 15.
So we're almost at 17 with him, which is a good thing, because you had mentioned that he has a strong bite. So.
Right. Right. And Drew, in case the audience asks about the upper left there, about cantilevering a future tooth, what's your preference on this situation?
Well, you hit on a number of things with regard to the bulk of the prosthesis. So the good thing is that you have a bulk of the material. You have to choose your material wisely. And there are certain guidelines that have been put out in the literature and giving guidelines as to how far you can cantilever. So there are also schools of thought that people don't cantilever. So for a gentleman like this, on the material, I would have no issue cantilevering, particularly if it was traditional crown and bridge. But here, what Charles is doing is he's going through the anterior posterior spread of the posterior implants and the anterior implants, and then he's going to run a calculation as to how far you can cantilever based on that. Is that what you're doing, Charles?
Yes, sir.
Yes. So there are some guidelines and some recommendations out there. Sometimes you even hear like 1.5 times the AP spread, which I think is crazy. But in this case, if we have that bulk and we're going to do a restoration that's robust, and you're going to use, ceramo metal, or if you have well fabricated or well processed zirconia, I think we're going to be okay because we have the bulk, and this guy can generate a lot of force. Again, I wouldn't advise fabricating a hybrid or a nano hybrid or a trilor type of appliance for this gentleman with the posterior cantilever in that situation.
With the AP spread math, it says that you can go 35 millimeters posterior from the most distal implant. So that's basically restoring the second molars, yes, if you wanted to. But in this instance, he doesn't really have teeth back there anyway. Anything we give him is going to be a vast improvement. So I think with what we have here, the prosthesis will be strong enough. We have enough implants and a good AP spread. And like you said, the thickness of the prosthesis, I wouldn't go much further than this.
I agree.
And we talk about AP spread. We also have good insertion torque values on these implants. So I feel like that helps out with the restoration as well.
You could tell.
Well, he has very
now,
good.
Dave?
Yeah, you can see from these sectional cuts. I mean, he has nice, solid. There's good width. The implants are well within the confines of the bone, and we're not using. The implants are definitely undersized slightly. Some of them we could probably use more width, but he's going to have nice torque values, I could tell, on these implants. And that's the nice thing of using the BLX is that a lot of times I under-prep the surgical site, and we're really able to get high torque values on the BLXs. And the nice thing with what Charles was saying before with these abutments is that they're already pre-planned, so we know exactly which ones we're going to use the day of surgery, but we always have backups just in case we have to change something.
Yeah, Charles, you're going to provide the abutments that you're...
Yeah, so we provide basically everything.
In the kit, correct?
Correct, yeah. You'll get the abutments and the cylinders as well. The cylinders will be pre-cut to fit the prosthesis, so you're not having to cut metal in the surgery. We also provide an angled guide that will show you which of the 6 positions the abutment needs to be in the right angulation for proper path of insertion.
And of course, we always get a backup denture just in case, right, guys?
Yep. The day you don't order one is the day you need one.
Exactly. You know, me and Dr. Pacinelli have no allegiance to any implant company. Which implants do you see being used the most, or it's so diverse today?
So I actually track what implant companies I send to production. I have Nobel usually sitting at 41%. I have BioHorizons at about 28%. Straumann comes in right around the same as BioHorizons, around 28%. And then everyone else is sort of peppered in there.
And I gotta say, I learned something at a course a few weeks ago. Is it true that all the abutments from all the companies, I think except for one, are universal in terms of the restorative head?
Pretty much, yeah. If you don't know what you're looking at, but you know, you could actually screw on a cylinder to both BioHorizons, Nobel, and 3i, and you'd never know the difference.
Yeah, it's pretty interesting. So I got a question for you, Dr.
Yeah,
Pacinelli.
but it's not about the part. It's about all the time it takes to fix it.
Yep.
Yeah. So for the restorative, for the PMMA, are we going to put a bar in or do with no bar?
Well, actually, we just started using a new material that doesn't require a bar. It's 3 times stronger than our previous provisional. It doesn't cost anymore, and it's easier to adjust in surgery because you're not having to grind through a bar. It's made of lucitone. It's monolithic lucitone, and I actually got the opportunity to drive my truck over one of these bridges, and other than a few divots that were from the asphalt, the thing held up.
Well, I have a question, Charles.
Sure.
Instead
I
of
think
sending
you're
the clear, can you send us one of those and one with the bar? Yeah.
Well, actually, we are going to send
Can you send me
two.
one of those all loose?
Well, our since all of this pandemic stuff happened, we actually are now sending 2 lucitone bridges instead of a clear dupe. The pickup process and the materials you use are all the same, but now you have basically 2 provisional bridges, one for the patient to wear, one for final records, or one for backup just in case.
Thank you, Charles.
Mm-hmm.
That's why I was going to see if we can use the one for the backup, but then the other one has a bar.
We could do that. I'm not too sure in regards to cost what that is. I heard some rumblings, but with the 2 lucitones, they're the same price. It looks like I have all the information I need to proceed with this case. We went through prosthetics, we went through implants, records, all of our prosthetic components. We're doing a backup denture. We're doing shade C3. Surgery is on the 10th. Gingival shade is a standard pink. Yeah, I've got everything I need to produce this.
I'm good with my questions and any feedback.
I'm good too.
Well, if you guys give me the okay, I will get working on this, and then I will send you the reports, the surgical reports, so you have them digitally. Yeah, that's it.
I think I'm good. Charles, you hit it again. Thank you.
Not a problem.
So that was the webinar that you just saw. The lab technician from nSequence, myself and Dr. Pacinelli added our details, our information. We asked the lab technician questions. We got to see all the different parts that we're going to have for the case. It's a great way to really review the case to make sure that we can move forward. If you have any questions, please feel free to contact us. And again, if you ever want to watch a webinar, I can always send you the email of any case that you want to see, and you could hop on the GoToMeeting in the future. So the next webinar will be the live surgery. So stay tuned for emails. Take care and have a great day.